Hello, everybody. I'm Dr. Mehrol Hasnan. I'm a retired psychiatrist, geriatric psychiatrist, and psychosomatic medicine specialist. Since I retired a few years ago, I have been working on a few academic, public education, and professional education projects. This is one of them. And this is, in fact, the introductory presentation for this project. And as you can probably tell from the title of this slide, I'm trying to promote, or I plan to promote, cognitive behavioral therapy in the developing countries. And why I picked this up as one of my projects, I'll explain it later as we proceed through the talk. So let's get started. Now, I'm in Canada, so I follow the Canadian Psychiatric Association, American Psychiatric Association, and American Psychological Association. Both American Psychiatric Association and American Psychological Association, as well as Canadian associations. And I assume the European associations and Australian as well, they strongly recommend that as a form of psychotherapy, we should adhere with the therapies that have evidence to support them. And if we look at the literature, there are probably tens of forms of psychotherapies. Some of them are very difficult to study. Some are relatively easily to study. And the strongest evidence is for basically cognitive behavioral therapy, then interpersonal therapy, dialectical behavioral therapy, and to a lesser degree for psychodynamic forms of therapies. There are other forms of therapies as well for which there is some evidence, but these four therapies are the most commonly practiced forms of psychotherapies. And so I decided to pick CBT from these different therapies because it has the strongest evidence, and it also is used in a very broad range of conditions. Now, when we talk about different therapies, all the professional associations, they also recommend that when we are incorporating the principles of those therapies, we need to show some clinical expertise and judgment and apply these therapies in a flexible manner. Now, this particular aspect of psychotherapies has been studied so we can figure out the major factors that are associated with optimal implementation of evidence-based psychotherapies. And this is a good paper. Whenever I'll cite a good paper, I'll cite data from a paper, I'll make a reference to it, and I would encourage the viewers to find the paper and read it, because I'm going to only cite compact reviews, credible reviews, good quality literature. So I strongly encourage any professionals who are watching these videos to consult those references as well. So Cook and colleagues, they basically did a review of literature, and they came out with a list of variables or factors that are associated with optimal implementation of evidence-based behavioral psychotherapies. The foremost they found was that therapeutic relationship, the nature of therapeutic relationship matters a lot. And this is, one can assume that too, that if it's a good therapeutic relationship, the psychotherapy interventions, they are going to work better. The patient is going to follow the therapeutic regime or guidance better. Second important thing is that when we practice psychotherapy, we have to show high level of fidelity to it. What it means is that most established forms of psychotherapies, they have a structure, they have a theory behind them, and then they have a certain structure or guidance to when we offer them. And whenever we are offering a form of psychotherapy, we have to stick with its principles. And I want to highlight this point because even in countries where we know that sticking with the specific form of therapy is important, during the sessions we tend to sway away. We might be offering CBT, but we might get into some psychodynamic elements, or we will be offering most CBT, but then we'll start discussing interpersonal problems or matters that do not directly relate to CBT or relate to the condition we are treating. So we have to be very particular about what sort of therapy or model we are following. In terms of the developing countries, I belong originally from Pakistan, and I know that over there is this issue as well, that because there is lack of expertise in specific types of psychotherapies, so usually they get offered in a more of a mixed format. So we have to. It's better to offer psychotherapies in a more specific format while sticking with their theory and structure, because that's where evidence lies. Now, while we need to show fidelity with the therapeutic format, at the same time, we have to show flexibility. So we don't want to come across in our therapeutic relationship too rigid. So we have to be a little flexible. We have to show, we can't just turn it into just a very structured, rigid format. So we have to show flexibility at multiple levels. And one of those is that we have to be flexible in terms of the context, and we have to take into account the context. So when we are offering therapy in an inpatient setting, it's different than we are offering in an outpatient setting. Similarly, if we are offering psychotherapy in a group setting, it's different than when we are offering in a one-to-one setting. We have to take into account patient characteristics as well, because certain patients may not have their mental orientation to CBT, and they may have better orientation for interpersonal therapy or psychodynamic therapy. So we have to look at the patient characteristics, and many of these elements I'm going to talk about them as these sessions continue. And finally, this study found that we have to be mindful of provider characteristics. So as it applies to the patient, that not every patient is cognitive behavioral oriented. Similarly, not every clinician is cognitive behavioral oriented, or some clinicians may not be oriented in terms of offering some other form of therapy. So you have to, the therapist also has to look into his or her own characteristics to identify what sort of therapy they want to offer, whether the patient is appropriate for that therapy or not, whether the diagnosis of the condition is appropriate for that particular therapy or not. And these will then determine how well any evidence-based psychotherapy gets implemented and what results you accomplish from it. Now, why I picked CBT from the major evidence-based therapies to promote in the developing countries, there are a few reasons for it. So first of all, in developing countries generally are stressed environments because they are relatively poor countries. There's a lot more competition than there is in the developed countries in terms of jobs, in terms of getting settled, in terms of finding the right job, education. So there's a high level of stress in those countries, and obviously that leads to stress-related conditions like anxiety disorders, mood disorders, depression in particular, adjustment disorders, even eating conditions, obesity. They're all stress-related conditions. Similarly, there's high prevalence of obesity, unhealthy lifestyle, and related conditions. And CBT is a form of psychotherapy that is effective in many such conditions. So if we can promote CBT in the developing countries and develop expertise for proper CBT, it can be a very cost-effective intervention for a broad range of conditions. And because CBT, of course, is psychotherapy, it doesn't involve medication, so we won't have the cost of medications, we won't have to deal with the side effect of the medications. And there are many conditions that CBT works as good as medications, or even better in some conditions. And finally, CBT is easy to offer training for CBT. Psychodynamic training is very difficult to offer just through videos. But in contrast, CBT, the basic training can be offered. And then once someone has basic training, they can then look at someone find locally to develop pretty specific training for specific conditions. And because psychotherapeutic training, it is an ongoing process. So the first few years or first several years, you usually discuss with somebody who is senior than you, more experienced. And then even after 5, 7, 8 years, when you yourself are comfortable, you continue to learn from your patients. And through the ongoing continued medical education. So at the same time, now when I'm trying to promote CBT in the developing countries, I see that the major challenges will be to promote fidelity. And as I mentioned before, because fidelity means that you stick with the principles and stick with the theory and stick with the guidelines of how you're going to offer that therapy. And for that purpose, you need people who are well versed with the theory and the practice of a certain type of therapy. And that's what I want to accomplish through these presentations. And another important barrier will be to make CBT culturally relevant. There's so much terms that we use here in Canada or States or in English-speaking countries with reference to CBT that I don't think there is an equivalent word for those terms in countries like Pakistan in the local languages. So we also don't have local studies about how to engage people in cognitive behavior therapies. So we will have to make these therapies culturally relevant, and it will be a long process. Now, in terms of the scope and format of what I'm trying to do, this effort will primarily directed at the health professionals. So it will be for doctors, for psychologists, psychiatrists, nurses, nurse practitioners, anybody who offers care in which cognitive behavior therapy can be integrated. Secondly, I will only focus on evidence-based CBT. And what I mean by that is that CBT can be offered in a broad range of conditions, but there are 7, 8, or 10 conditions in which there is evidence of there is strong evidence of its efficacy in a few conditions. So I'll try to keep perspective from those conditions. Thirdly, I will cover the basic and applied aspects of CBT. I won't go into discussing how to offer CBT in specific conditions. I might mention them, but I won't go into the details. For example, I have offered CBT for obesity and healthy lifestyle interventions. So that itself means that you need to develop a course for that. And once you have that will involve specific type of interventions and specific methods and all that. So I'm not going to go into details about specific conditions. Finally, these will be the recorded videos that I'll share with you, and the videos will be, I'll post them, upload them on YouTube, as well as in a Facebook group that I created yesterday, in fact. Now, on YouTube channel, I don't expect, and I will not have time to get into academic discussions or further elaboration of what I meant or further discussion. But in the Facebook group, I do intend to to post other material as well and engage in discussions as well. So here is the link for the Facebook group if you want to join it. So you just send a request to join it, and if you're suitable, I'll let you in the group. It is a closed group, so you will only be able to see the posts and engage in the discussion if you are a member of that group. So that concludes this particular presentation. I'll give it at least a week or maybe 2 weeks so that I can gather a few more members in the Facebook group, and then hopefully I'll start uploading on average about 3 to 4 videos per month, and slowly it will cover most of the basics and applied aspects of CBT. Thank you very much for watching this video, and if you think you can, somebody else can this can be of use to anybody else, please feel free to share it. Thank you very much. Bye.